Okay.
Oh, okay. Can already.
Can you all see now everything?
Yes. You can see very clearly.
Oh, thanks. Can you hear me?
Yes, you can hear you
Okay.
as well. Okay, then.
Can you hear me clearly?
Yes.
Okay, thanks. And sorry for the delay. I don't know what happened just now. Even my MA couldn't help me, and he's usually good at all these technical things. Okay. Okay, shall we proceed? I think the rest of the participants already got a 15-minute break because these are quite heavy lectures. Okay, so throughout the lecture, I'm going to use the word ASM, anti-seizure medication, is different from AED. AED is anti-epileptic drug. Okay, so the reason is epilepsy medication used to control seizures are not treating the epilepsy. They are not epileptogenic. Okay, so the term has been changed a couple of years back to anti-seizure medication, ASM, right? Okay. So today we are going to go through the basic concepts of childhood epilepsy, because before we start medication, we need to know what we are dealing with. The new classification in 2017 actually is not new now, but some of you might not be aware. So I'm just going to show it because it is important when we actually choose the medication, and then how to evaluate to choose the anti-seizure medicine, which I told you is ASM, not AED. Then choosing the ASM based on seizure type and epilepsy syndrome, some practical points of anti-seizure medication therapy. If we do have time, we'll take you through some clinical case discussions, and then I will summarize the whole thing. So just bear with me. If I'm going too fast, just let me know. So what is an epileptic seizure? Basically, when you have a seizure, this is what you see, but in your brain, there is an abnormal, excessive, synchronized discharges of a hyperexcitable population of neurons. So normally our neurons are always discharging, but when all this comes together, and in epilepsy, this group of neurons are hyperexcitable and they're excessive discharges, so they discharge. And depending on where the neurons are in the brain, then you get your clinical manifestation of what you see. And the seizure can be a motor, sensory, autonomic, or psychic in nature. This was a 1973 definition. So epilepsy is actually recurrent seizures. When you have one seizure which is unprovoked, you cannot say that it's epilepsy. You have to have recurrent seizure, more than one seizure. And the actual definition is you are actually having a brain disorder, and you have this predisposition, and it's not a transient predisposition, it's a long time predisposition to generate these epileptic seizures because of this hypersynchronous excitable group of excessive discharges in the neurons in the brain. And this disorder will give rise to all the other complications that you see when you treat an epilepsy patient. You got a learning problem, you have cognitive, you have behavioral problem, and all the consequences because it's affecting the neurons in your brain. So you not only get the actual clinical manifestations, you also get morbidities together with this epilepsy. So how serious it is and how important this topic is, I cannot emphasize it more. It's actually in the world is the second most burdensome neurologic disorder in terms of disability adjusted life years, okay? And it's affecting worldwide children, about 1% of children, and it's the highest incident in the younger ones and biphasic distribution of age group, and also in the elderly because more pathology in their brain. And among all the patients that you and I will see, especially in our tertiary center, 20% of them will be uncontrolled seizures with significant morbidities. So whenever you choose anti-seizure medicine, I need you to go through these 3 questions in your brain. And this is what you need to remember, and this is what's going to come out. So it's not just choosing the medicine, okay? Okay, patient come with some movements, and you say this is epilepsy, and you choose the medicine. So the first thing is not like that. So the core clinical approach should be, is this a seizure? That's the first question you ask yourself, because 33% of children who came into a tertiary epilepsy center in an advanced epilepsy center overseas, about 30% of them do not have a seizure, do not have epilepsy. What do they have? They have a paroxysmal non-epileptic event. So it's non-epileptic. So not all everything that shakes and jerks are seizures. So this is the first question you have to ask yourself. Briefly know what's the classification of seizure type, so we know what medication to choose. If possible, try to identify the epilepsy syndrome, and of course, this won't be complete if you don't determine the underlying etiology, and there are 6 broad groups of the underlying etiology that is in the 2017 classification. It goes hand in hand. So as a doctor, to have a holistic medication of the patient, you need to assess the functional deficits and the comorbids, because each child will have different functional deficits and different comorbids, and this will help you to choose the medication. Later, I'll show you some examples. And I'm not going to go through the history taking, physical examination, investigations like EEG, neuroimaging, neurometabolic, and neurogenetic tests, but all this has to be done, and then the whole thing will help you to make a right choice, choose the medication. So these are the position papers that my lecture is, my talk is going to be based on. As you can see, is 2017, where International League Against Epilepsy, ILAE, came up with this new classification. So the first part of the classification will be seizure type. What type of seizure are we dealing with? Is it a focal seizure? Is it a generalized seizure? Or do we not know the onset of the seizure? So the first thing is seizure onset. If it's focal, if it's generalized, or we really do not know. And this is okay. It's okay to say we don't know, okay? And the next will be what type of epilepsy. So if it's a focal onset, is it a focal epilepsy? Is it a generalized onset? Is it a generalized epilepsy? You may have we actually not know until we get the investigations done, is complete, then we can know. And you see on the right hand side of the arm of this graph, you have all the major etiology, as you can see it here: structural, genetic, infectious, metabolic, immune, and still we cannot know the etiology. So this unknown is okay to say if you don't know, but we have to try our best to find out as a doctor. But if at the end of the investigation, if you don't know, it's fine. So the third level will be epilepsy syndromes, and it does not end here, and you have to assess the patient's comorbids. So this whole graph is very, very self-explanatory. If you kind of know this graph, you can actually refer back, and when you see an epilepsy patient, you can base your classification on that. And this is also important for research. When you refer the case to a neurologist or you want to present a paper, you go back to this classification right now. So focal onset, one part of the brain, if the expanded classification, if your focal is coming from one side of the brain, are you aware or are you not aware? Then you have a motor. Do you have a clinical onset that is motor, or is it a non-motor inset? Or does it progress to focal and bilateral tonic-clonic? If you notice, the name of generalized tonic-clonic is no longer being used. Dulu kita, we will sebut is focal to generalized secondary generalization. We do not say that now. We say it's bilateral tonic-clonic. And we do not say partial seizure. We do not say complex partial seizure. We do not say simple partial seizure. We say focal onset with intact awareness or impaired awareness, depending on what the patient presents as. Sometimes it's hard to be sure unless you test the patient. So don't worry too much about this. Then is it a motor phenomena or is it a non-motor phenomena? And we do not say it's generalized tonic-clonic. Generalized seizure, same, motor or non-motor, okay? And unknown onset, again, we don't know where it's coming from. Is it focal, generalized? Is it both? Motor or non-motor, and is unclassified. So in this, is a more practical classification to allow doctors to initially say that I do not know, and then later as the diagnosis and the evaluation becomes more clear, then you can put a finding into the correct evaluation and a correct working diagnosis. So when you say generalized seizure is at some point within the brain, but it's not really from any particular spot, but all you see is a generalized bilateral distribution of networks. This one patient won't have the aura. Whereas if you say it's focal seizure, patient can have focality from any part of the brain, but it doesn't stay there. Okay, it doesn't stay there. It can go to other parts of the brain and you can get the manifestation there. It can be localized in this hemisphere or it can go to another hemisphere. So how the onset is the aura, where the patient starts having the seizure. If the patient is big and cognitive, if the patient is older enough and the patient is cognitively normal, the patient can describe an aura to you. Okay, and then it can be widely distributed. So expanded version is, just now I showed you focal, generalized, unknown, aware, if focal is aware or not aware, motor and non-motor, and don't worry too much about this. You can always open the book and check on this, okay? You can open the book, protocol book, and check what type of seizure this is, and it's important to have a video. Always try to get a video of the seizure so you know what you're dealing with. So these are the type of manifestation. So under non-motor, you got absent seizure, whether it's a typical absence, atypical, all these other things. And of course, there's a classification called unclassified. So now we are going to talk about a bit about the epilepsy syndromes, because just now we went through the types of seizure, motor, non-motor, and all these things. So now we're going to talk a bit about epilepsy syndromes. And it's fairly important because 30% of childhood epilepsies can be initially classified into an epilepsy syndrome, okay? If possible, we want more, but this is at the initial phase. We can classify most of them, and this will help us to choose the anti-seizure medicine. So if you're wondering why is Dr. Vicky not talking about which medicine to choose, I'm coming to that, but I think you need to know these basics first before you choose your medications. So now when you talk about epilepsy syndrome, what is it? So how do you put a patient into an epilepsy syndrome? So you need a semiology. When I say semiology, it means from the onset, what the patient is doing, and what is the manifestation, step-by-step manifestation of the patient. So from the onset, if there's an aura, does it involve the arm? Which arm? Does it proceed to the leg? Those kind of things, okay? Then the age of onset is very important. The development of the child, the EEG features, okay? The background, the EEG pattern. Sleep EEG is very important because without a sleep EEG, the epilepsy syndrome may not be clearly shown, because a lot of the epilepsy syndrome, the EEG abnormalities only come out during sleep. Sleep is the activator of EEG abnormality. So if you have a awake EEG that's normal, it's not good enough, okay? You must get a sleep EEG, because most of the self-limited epilepsies, focal epilepsies, sleep will be activate the abnormal EEGs, including the generalized epilepsy. And of course, the best would be to capture the seizure with a video EEG. Then to see when a patient is having a seizure, what is happening in the brain. And this will also help you to classify the epileptic syndrome. Where is the patient having the seizure? Is it a focal? Is it a generalized? And then to choose the anti-seizure medicine. Of course, it's not complete. All the epilepsy patients need, most of them, except for the self-limited epilepsies, need the MRI brain. And now, as you would have heard Dr. Sindhu talking, the metabolic and genetic studies are becoming increasingly important, the genetic studies. And once you diagnose one syndrome, it doesn't stay. It doesn't stay as one syndrome. It can go on from one syndrome to another. Okay, in a baby, you can get a developmental epileptic encephalopathy, DEE. And then at about 5 months, you can get infantile spasms, and about 3 years, you can get the same patient moving into Lennox-Gastaut syndrome, okay? So IS is infantile spasms, LGS is Lennox-Gastaut syndrome. So it doesn't mean that one, you have let's say you have a infant about 3 months old and you have a horrible EEG and tonic seizures, and you diagnose the patient to have a DEE, developmental epileptic encephalopathy. Patient may not stay there. Patient can evolve into a infantile spasms, when the patient becomes into that age-related maturation of the brain, and later on into childhood can evolve into Lennox-Gastaut syndrome. So the brain is plastic, okay? So it can change. Don't worry, even neurologists cannot diagnose a child, every child with a syndrome, so do not worry, but be aware of it because it's important for choosing the medication and to give the prognosis. If a DEE is bad, okay? And you can tailor the genetic investigations or the metabolic investigations accordingly. And later I will show you, this will help you to choose the therapy and avoid the aggravation. Certain syndromes are aggravated by certain anti-seizure medications, all right? So this is not for memorization. This is for you to know that the 2021 classification, 2022, they have revised all the epilepsy syndromes, and the syndromes that you see in your protocol, pediatric protocol 4th edition, is not all of them are valid anymore because the classification from 2022 has come out. You don't have to memorize this. I'm revising the epilepsy chapter for the 2023 5th edition of the pediatric protocol. So you will see this graph and you can always use it to check. Even I cannot remember this, so you do not worry about that. So what I'm trying to impress upon you is that the syndromes come on with certain ages, okay? So these are the syndromes that you can get, and these come on certain ages. So age of onset is important. And this is the bad epilepsies in red, very bad. This is the syndromes with developmental epileptic encephalopathy and with progressive neurological. These are really bad. These are really bad. And these do not respond to medication, and definitely you all at the pediatric level cannot treat these patients. Even we cannot control the seizures because of the bad prognosis, but you should do a timely referral so that we can tell the parents, rather than changing many medication and it doesn't help, we can tell the parents what type of epilepsy that we are dealing with. So now, when you treat childhood epilepsy, what do you expect? These are children who are first diagnosed, not the old epileptic patients. Actually, about 2/3 of them will become seizure-free with no treatment, or they respond to low and moderate dose of the first or second choice medication as monotherapy. Okay, I think this will be, most of it will be in your hospitals, and these are the patients who do not come to me. So majority of them do respond to either one or second, okay? But the ones that we see in a tertiary center that need pediatric neurologist input are the ones that are 30 to 40%. They are difficult to control, but later on, maybe the outcome might be better if you control it early. You don't miss the window period. You give it the right medicine. Although these patients may have comorbids, all right? Comorbids like learning difficulty, behavior problem, etc. And the remaining 10 to 20% of patients are long-term intractable epilepsies despite multiple anti-seizure medicine. So there'll always be small group, and these are the group that will always see us, all right? So I know why the topic for this talk. Can you imagine how many medications we have? Huge number of medications available, especially from the year 2000. There's an exponential increase in the number of medications, and we don't have all of them here. So I've tailored the next slide accordingly. Those who are available in Malaysia, the older anti-seizure medications, I'm going to use some of these abbreviations. I'll try to let you know the names, but these are the abbreviations. Sometimes we also need steroids and immunoglobulin if there's an underlying immune mechanism, or in certain types of DEEs. And then you have a newer anti-seizure medicine. Actually, lamotrigine, topiramate, levetiracetam, and clobazam are not new. They are quite old already, at least about maybe 10 years or more. Okay, so the newer ones I'm not going to mention here because it is not at your level. So I'm not going to mention the other things. Some of the newer ones are rufinamide, perampanel. Okay, so the others special, this is a error where the pediatric neurologist can come in. But vigabatrin, I think you heard quite a lot about it from Dr. Sindhu's talk, so I'm not going to talk to you about that. So choosing anti-seizure medicine, I think I'm also like this, and I'm sure you'll be very, very perplexed and have this look, and I think my head also will be pushing, but it's okay, we can go through this together. Now, how do we choose anti-seizure medication? Ask yourself, is it epilepsy or is it not epilepsy? Because I'm going to, hopefully we get some time to show you some cases. Then you try to identify the seizure type, try to get a video, try to see what type of seizure the patient is having. Of course, the best will be a video because a picture speaks 1,000 words. Because when a patient is sitting, parents can't remember. They'll be so panicked, okay? They will panic. They will not remember which hand, which leg, which what happened first. It's very difficult. And we try to identify the epilepsy syndrome because this will influence our anti-seizure medications. So, okay, I've used the medications recommended is from many databases, especially the NICE guidelines, up to date, and randomized control trials that have happened mostly in adults and then postulated to children, all right? Most of the randomized control trials are in adults, and these are actually more for safety of the medication rather than the efficacy, all right? So as I told you, is it a seizure? Then you go for seizure type, and if you can identify the epileptic syndrome, when you start medication, parents will want to know the side effect, and is the patient able to tolerate the medication? Kindly know which anti-seizure aggravates which seizure type so that you do not use that. Patient's factors, if it's a very obese child and gaining so much weight after you started sodium valproate and the weight has gone up so much, you might have to look for another medication rather than sodium valproate because the weight has become very, very increased. Or if the patient has side effects like hand tremors or massive hair dropping, which is a effect of sodium valproate, then you may have to choose. So some of the factors like, is it a hyperactive patient? Is it a patient with a lot of hyperactivity, aggressiveness, a lot of behavior problems? Then you will not choose levetiracetam. Or is it a very thin underweight patient? Because you know that giving topiramate can suppress the appetite. So you need to know some of these comorbids. Is it a cerebral palsy patient who can't swallow, who's choking on his secretion, has plenty of secretion? Then you have to avoid some of the benzodiazepine because it can cause hypersecretion. That's what I meant by patient factors and comorbid. Now in government, we are fortunate. So we don't really think much of the cost. We just prescribe. But however, for us pediatric neurologists, we do have to consider the cost at some point in time because we are also limited by the budget. How much can the government buy for us? Because some of these medicines are very expensive. So it is actually as you can see, it's a multidisciplinary holistic approach, but each patient is different. So it's an art as well as a science, all right? So at the same time, don't forget to investigate the cause. As I told you, the comorbids. So this will help you to predict the outcome. You can tell the parent what type of prognosis. And you have to weigh the balance between controlling the seizure and setting goals to control the medicine at the expense of the quality of life, okay? So it's a balance between the seizure control and quality of life. Lennox-Gastaut, you can't expect the patient to have 0 seizures and because you still know that these are refractory seizures. So you keep on piling up the medicine, but patient is like a zombie. You know, the secretion piled up, the patient is so sleepy, the patient can't learn, or the patient becomes very aggressive. So it's always a balance, all right? So your education and counseling is very important. And you also need to take parents and child's views into account. All right. So this one, you don't worry, is in your protocol book, but this one has been changed because I've done the 5th edition. So you will get the 5th edition, but there will be a few minor changes. So if you have focal seizures, our first line is carbamazepine, but I need to tell you that this day and age, you need to do a HLA-B 1502, should be tested because of the Steven Johnson's agranulocytosis. We can't afford to start patients, but having said that, I have started patients if the parents are under my direct observation in a very tiny dose, if the parents are agreeable that this could be a potential side effect, but it's taking a risk unless you really have no choice. All right. And then the second line can be any other of these medication that I've written here, depending on patient comorbid. And under generalized seizures, you got many types of seizure semiology. You got tonic-clonic, valproate, lamotrigine, Keppra, levetiracetam. Absent seizure will be valproate, first line. Etosuximide, overseas use it. We don't have it in the blue book. It's only used for absent seizure, typical absence. It doesn't work for generalized seizure. I've used it for a few patients with a KPK who don't respond to valproate and lamotrigine. Second line is lamotrigine. 95 of my patients with absent seizure actually responds to valproate add-on with lamotrigine. Okay, so this is the medication for childhood absent seizure. Tonic, atonic, valproate, lamotrigine. Second line will be clobazam and topiramate. Rufinamide is only used for tonic seizure associated with Lennox-Gastaut. Myoclonic, again, valproate, levetiracetam, and then second line, you can use other benzodiazepine and other medications as well. Now, going back to epilepsy syndromes, what are the epilepsy syndromes that are available to us? And if you have infantile spasm syndrome, this is a new term. You use a first line steroids, high-dose prednisolone and vigabatrin or vigabatrin. And if it's this vigabatrin is the first line for those with tuberous sclerosis with infantile spasms. And if it doesn't respond, you quickly refer to us. Anyway, you do have to refer to us anyway for guidance. Dravet syndrome, sodium channelopathy, genetically proven. Sodium valproate clobazam and the second line, and you have to avoid things like lamotrigine and phenytoin carbamazepine. It makes your Dravet syndrome worse. Lennox-Gastaut, sodium valproate, lamotrigine, and then the second line, your bet is as good as mine because these are rarely responsive to, rarely able to get full seizure control. So you have a couple of more of epileptic syndromes like myoclonic atonic seizure, previously known as DO syndrome. Your first line is sodium valproate, lamotrigine, clobazam, and your second line can be a ketogenic diet and levetiracetam, which is Keppra. Absence, epilepsies. Etosuximide is not available in the blue book, so it's a KPK item. It's only used for absence. This one, I think I told you earlier. Juvenile myoclonic epilepsy, myoclonus responds to sodium valproate, levetiracetam, okay? And our Rolandic epilepsy has changed its name in 2022 to SELEX. SELEX, self-limited epilepsy with centrotemporal spikes. Before you get the carbamazepine on board, you need to do a HLA. You can use levetiracetam or sodium valproate and maybe second line lamotrigine. Rarely in these children with Rolandic, SELEC, if they have evidence of neuroregression, a referral to neurologist is suggested because they can have atypical manifestations in the EEG and they do have developmental regression. You need to ask this question when a Rolandic patient comes to you. Anti-seizure medication that may aggravate selected seizure types. Okay, phenobarb we don't use for absent seizure. It aggravates it. IV benzodiazepine can precipitate tonic status in Lennox-Gastaut. Carbamazepine is good for focal, but it aggravates absences. It aggravates myoclonic, and some people it can also aggravate GTC. Lamotrigine is contraindicated in Dravet syndrome. Sometimes it makes the myoclonic seizures worse in juvenile myoclonic epilepsy. And same with phenytoin. These are all sodium channel blockers. It can aggravate absence myoclonic seizures, and same with vigabatrin. Don't worry about this. You can't remember. You can open up your protocol book. This table is there. I'm not going to go to individual medication and individual adverse effect. Nobody can remember everything. So please open up your protocol book. Please open up Dr. Google, check on the adverse effect. Ask your pharmacist, check on Minidex, MedX. You can check on all these. Each drug, you can look at the general side effects, okay? So when you choose anti-seizure medication, it's not AED, sorry, it's anti-seizure medication, forgot to change that. So there are major groups of broad adverse effect. They can be CNS effect. I'm just going through broads of effect. So this is more for the older anti-seizure medication. Is dose dependent, drowsy, dizzy, ataxia, patient can't learn, okay? Behavior and mood, irritability, aggression, hyperactivity, insomnia, they can affect something. Sometimes benzodiazepine, paradoxical effect on this. Levetiracetam, which is Keppra. And then you have this group of idiosyncratic reactions. No matter what the dose is, it can come out and it can affect the child. Rashes, Stevens-Johnson syndrome, agranulocytosis, vigabatrin with its visual field defects is not dose dependent, hepatic failure in valproate. So you avoid valproate in patients who are, if you have not confirmed whether the patient has a metabolic or mitochondrial disease. So how do you use anti-seizure medication to treat? So you try monotherapy, you choose the best medication to optimize the medication. You titrate it slowly, not overnight. You go it weekly to weekly, depending on the anti-seizure medication. The policy is as much as necessary, as little as possible. Okay, and you maintain, you give it an adequate trial, and you review early to reassess. And 2/3 of your patient will enter long-term remission on a single monotherapy. So what happens if your first anti-seizure medication fails? You can add on the second anti-seizure medication, and you can see if you can withdraw the first anti-seizure medication once the second medication reaches therapeutic levels. And this is called alternative monotherapy. You don't have to keep both of them together. You can see if you can withdraw the first one. And then you come to combination of polytherapy, where you combine anti-seizure medication with different mechanisms of action. Do not give the same groups of actions like sodium channel blocker, phenytoin and carbamazepine. They are sodium channel blockers. Phenobarb and benzodiazepine both work on GABA receptors, both cause secretion. Try to avoid combining these medications together. Look at the pharmacokinetics and dynamics. Can discuss with your pharmacist on that. Sodium valproate is good for absence seizures. Sodium valproate and lamotrigine. If needed, a benzodiazepine is good for a group of seizures of myoclonic, absences, and generalized tonic-clonic seizure. This is a good combination for those. And only 5 to 10% seizure control can be achieved if you already tried 2 or 3 medication and all of them fail, okay? So this is also not for memorizing. When you want to combine medications, you can look at the which are the medications that have sodium channel. Now, which are the medications that have GABA, and you can combine both of them, different mechanisms of actions together. You can always check on that. So how's the response generally to medication? Children with genetic generalized epilepsies and self-limited childhood epilepsies like SELECT are likely to respond rapidly, and they are not significantly affected in their learning. Children with symptomatic epilepsies that have an underlying cause, maybe previous HIE, previous trauma, previous NAI, They have a variable response to anti-seizure medication, often need more than one. They have a learning and behavior problems, and patients with developmental and epileptic encephalopathies, DEE, are quite refractory with significant neurological deficits. Can I know what time I finish? Somebody can tell me what time I finish?
You can, Dr. Vicky, you can extend up to 12:45 p.m. No
But
issue.
what time are y'all starting back again?
We'll be starting back, okay, at 1:30 p.m. 1:45, sorry, 1:45 p.m.
1:45 p.m.
Yes.
Okay, so what I'm going to do is I'm going to go to the summary for you first, then we discuss the cases. I want to wrap up the things so that you all are clear in your mind, all right? So I'm going to go quickly and okay, I'm going to go quickly and I'm going to, okay. So I'm just going to summarize the whole lecture for you, then we can see some videos because we are a bit short of time. So I want, if you, let's say you can't remember whatever I said before this, I'm going to give you some take-home points. So choose the anti-seizure medicine based on the epilepsy syndrome, ideally, but of course, it's not practical. Even I cannot do that. So we choose the anti-seizure medicine based on seizure types. Try to get a video from the parents. It will be greatly helpful. If you have a video that shows it's obvious generalized tonic-clonic seizure, choose valproate, but there is a product insert, avoid valproate in women of childbearing age because of the teratogenicity of valproate in women who are expecting, okay? Many side effects, cleft palate, spina bifida, cleft lip, cardiac malformations, autism, learning difficulties, renal issues, and a lot of other things as well. So if it's a generalized tonic-clonic seizure, we add on lamotrigine, or if valproate is unsuitable for women of childbearing age, we can use lamotrigine as the first line, but be aware in juvenile myoclonic epilepsy because of the myoclonic seizure sometimes can get aggravated, is contraindicated in Dravet syndrome. In absent seizure, choose valproate and add on lamotrigine. And in a few of my patients that don't respond to they do very well with etosuximide, which I purchased on KPK. Newly diagnosed focal seizure, confirm with your video, confirm with the MRI findings. It's a focal pathology, confirm with your EEG abnormalities, choose carbamazepine, but please be aware and screen for HLA-B1502 before you start. If you cannot start carbamazepine while waiting for the results, you can try a second-line medication depending on the comorbids, levetiracetam, lamotrigine, and of course topiramate much later because of the side effect profile of topiramate. Self-limited epilepsies like those with occipital epilepsy, cough, pole, select, okay? You can choose carbamazepine or levetiracetam while waiting for the HLA. Now, benzodiazepines like clobazam, clonazepam, diazepam, we don't usually use oral for diazepam and midazolam, but we use usually clobazam a lot. Some of the younger ones sometimes use clonazepam, but beware of the secretions. Broad spectrum in various seizure types, but may be limited by the adverse effects of hypersecretion, paradoxical, irritability, and also tachyphylaxis. When I say tachyphylaxis, that means that after some time, the benzodiazepine doesn't work. You need bigger doses, and after that, it doesn't work. It works for a while, then the body gets used to it. So that is called tachyphylaxis. But it does make a good combination for with valproate and lamotrigine for generalized seizure types. Repeating myself, infantile spasms, evidence-based. Steroids or vigabatrin depending on family's view for non-TS cases, but for TS cases, Vigabatrin is proven to be superior. Do look for triggers and precipitant of seizures. Is there a fever? Is there lack of sleep in the patient? Is there stressors at home? Is there lack of compliance? Okay. Look for correctable causes of seizures like metabolic abnormalities, low sugar, low calcium, low sodium, and correct them as well. Now, if you don't have response to anti-seizure medication, keep in mind the vitamin responsive epilepsies, like those infants and those below 3 years old who have difficult to control epilepsies. Vitamin B6 needs to be given to them. And you also have metabolic diseases and things that will have some of them may have a particular treatment or a particular diet that can help with the seizure control. So vitamin B6, folinic acid, biotin responsive epilepsies need to be kept in mind. If they don't respond to the first anti-seizure medication, or if you think that this is a refractory epilepsy from the beginning, especially in infancy. Immune-mediated seizure, because the patient might be having an underlying Rasmussen's encephalitis, which I'm not going to tell you here. And also, more important that you and I might see is autoimmune encephalitis, anti-NMDAR autoimmune encephalitis, which presents with focal seizures initially, or generalized seizures, or even status, and then they may have associated evolving behavioral issues. Or if the patient actually has a lesion that is operable and we are not bothering about that, all right? If the patient is not responding, what are we going to do? What are we going to think of? Have a checklist. Is it a seizure or is it not a seizure? We might be treating non-epileptic events and that's why patient is not responding. Is it a wrong classification of epilepsy syndrome and seizure type? That's why you chose the wrong medication. The patient and the parents is telling you, yes, I'm compliant, but actually they are not compliant. You have to be smart to get your answers from the patients in an indirect way. Or you quickly switch medication before even giving it a proper dose. You quickly switch it without a proper excuse, without a proper reason. You switch one to another, and finally you don't know whether the first medication could have worked if the dose has been correctly done. Or have you chose a medication that is aggravating this epileptic syndrome or aggravating the seizure type, like absences? You are giving him carbamazepine because a patient present with blank, staring look, and then you thought that it's a focal epilepsy. You start carbamazepine and patient goes into absent status. Is it an epilepsy with a lesion, but a radiologist has reported it as a normal MRI? We need to review and look at the MRI again. Or are we dealing with a progressive neurometabolic, neurogenetic, a progressive degenerative disorder that is going bad no matter what you do? And when you have to refer the patient to a pediatric neurologist, this is also very important. Infantile spasms, definitely, because the longer you wait, every 2 weeks, the IQ drops by more than 10 points. It's been proven in studies. Seizures with developmental regression, that it shows that is something very serious going on. Poor seizure control despite monotherapy with 2 different anti-seizure medications. Need somebody with, with more experience to help to sort out this problem. Difficult to control epilepsies beginning the first 2 years of life, where the window period is there to optimize the development of the child by doing the right thing. Or you have a structural lesion on imaging because it's not going to respond, but it's a hidden structural lesion. You are reported the MRI is normal, and that's it. So I'm going to share with you some of my cases. I have a few more minutes left, and then you can see how to, let me just share with you some cases. Hopefully y'all can see the video. So have a look at this patient. The baby's asleep. The baby is about 6 months old. And you can see the jerking. Actually, you see the jerking more on the right arm, but also the left jam is jerking. And parents actually did not take the leg. Sometimes the leg jerks as well. And it happens only in sleep. Only in sleep. So this is a benign neonatal sleep myoclonus. You can see the neonatal period or the infancy period, and as they grow, it will resolve. So you only need to reassure. You wake up the child, there's no more of these jerks. The child does not get the myoclonic jerks in the awake state. The development is normal. Some of them ended up getting EEG, and of course the EEG is normal, all right? So I'm putting this on because I told you the first question you have to ask is this a seizure or not? And it's real because throughout my career, I have got about 4 or 5 patients coming in. Really, this is not, I'm not just telling you for the talk, but parents have come as far as Perak and Kedah, carrying their child bursting into my room because they want to show me the patient having massive jerks during the time patient is sleeping, and patient has been put on phenobarbital, started on clonazepam, started on pyridoxine high dose, and lumbar puncture done, and even treated for meningitis. So I think this is something that you need to recognize, all right? It only happens in sleep. Development is normal. And when you wake up the patient, it does not happen. All right. So I want to ask yourself, the first question is this a seizure? All right. So you need to review the diagnosis. Is it a seizure or is it a paroxysmal non-epileptic event? And you have a lot of this. Is also in your pediatric protocol. You can have a lot of other things mimicking epilepsy. Okay, have a look at this patient. She's a 5-year-old girl. She presented with a frequent blank episodes in school. Her teachers complained, and even her mom noticed her having all these blank episodes. Listen to this. Okay, as you can see, the patient was doing a hyperventilation test, okay? So there's lack of time, so I'm not going to ask you what the patient had during the time the patient, you see that the patient is wired up with the EEG. So when she was going blank and the technician was calling out her name, Atika, Atika, she did not respond. But what was happening in her brain? Can you see? This is 1 second. One box here is 1 second. So you can see that is 3. Okay, so the box is here, here, and here. So you got 1, 2, 3. 1, 2, 3. This is 1 second, so it's 1, 2, 3. So this is 3 Hz spike and wave. This is a normal awake EEG. And this child has childhood absence epilepsy, and you will not give her carbamazepine, you give her sodium valproate, and if she doesn't respond, you will add on lamotrigine. Oops. Can you all see this? So both of them, did you all notice that both of them had a sudden drop attack? Okay, you can have a look again. She's reading a book and suddenly drop attack. So you need a video EEG to see whether your drop attack is a tonic seizure, is it a myoclonic, or is it an atonic seizure? So when you have that video EEG, then you will choose the appropriate medicine. If you see a generalized, both of them at generalized polyspikes, and the drug of choice will be sodium valproate and add on with benzodiazepine and lamotrigine. Okay. Can you hear the sound as well?
No, sorry, doctor, actually we cannot hear the sound of the video.
Okay, you just listen. It's a very soft sound. Can you see the video?
Yes, we can. We can see the video.
But the sound you all can't hear lah.
No.
Okay. Anyway, each time the child drops, he's saying up like that, up, like it's like a forceful contraction. Okay. So it's all happening in clusters, repeated clusters. So that's why I say the video is very important. So you can see this child, just notice this child, what happens? That the child, when she drops, she said, like that, okay? So it's happening a couple of times. Again. So this is a very bad EEG. I showed you the normal EEG just now, right? So a very normal organized EEG. Look at this EEG, it's chaotic. It's actually infantile spasms. And during the time the patient is having a spasm, you get a ictal spasm. So the importance of the video EEG, all right? And one of these child, they had a structural lesion, one side of the brain, and has gone for epilepsy surgery, okay? So one side of the brain is abnormal. Right side of the brain is hemimegalencephaly, and you can see that the patient presented with infantile spasms, and the right side of the brain is abnormal, and the right side of the EEG is discharging away. So this patient successfully went for epilepsy surgery and he's been seizure free. Okay. Okay, this is a baby. Can you see a tonic? Patient is having a tonic seizure and is turning blue. There's no clonic movement. It's a tonic extension of the seizure. Can you see that? And it's multiple seizures. Can you see? So it's a tonic extension of the right arm, face and eyes deviated to the right. When a patient comes to me and show me the video, I do not know whether it's focal or whether it's generalized, but the EEG is very bad. It was a developmental and epileptic encephalopathy, and I'm just showing this slide because the role of genetics as an etiology of epilepsy, all the epileptic syndromes, this child turned out to have a STXBP1 gene deletion. So every of these epilepsy syndrome have multiple genes. So this is a bad prognosis epilepsy. So this is important. The role of genetics as an etiology of epilepsy, not meant to memorize, not meant to learn, just to know that there's such a thing and there's a lot of this happening now. Okay. So this is a only focal of the right arm. Okay, can you see only focal of the right arm? So it's a focal epilepsy, and you need to look at the MRI. You need to investigate accordingly and choose the correct drug. This is showing you how you choose the drug. You see focal, but having said that, you think that it's a focal, you want to give her carbamazepine, but later on, this child came in with, just now was right focal, right? You saw it's a right focal, clonic movement of the arm, and came in status epilepticus. 2 weeks later, after she went home, she came in with, just now is right, she came in with left focal status epilepticus. So alternate between left and right, and she presented with recurrent episodes of status epilepticus, sometimes associated with fever, sometimes not associated with fever, sometimes being unwell. And this quickly rang the bell for us. For me, that is Dravet syndrome. And if you think it's focal, that I would have started carbamazepine, but thank God I didn't, because I investigated. I was worried about this patient, whether it could be Dravet because she presented with status epilepticus, and it was a focal on the right, then later on became a focal on the right, left, and her SCN1A gene was positive, and this is Dravet syndrome. So I'm glad that I did not start her on carbamazepine. Okay, this is a boy who came in from another hospital. Okay, he was thought to have, actually the pediatrician thought that he was trying to get out of not going to school, and did all the movements that you saw he did, all right? So they didn't think that it was a seizure. So my first question, is it a seizure? I had the video, I had a look at the videos, multiple videos, all about the same, all the same seizure semiology. I don't have time to ask you, but I'll tell you the answer. It's a myoclonic seizure. You saw his myoclonic jerks. If you get him to hold something, the thing will fall. And this boy has juvenile myoclonic epilepsy. And we started him on sodium valproate and levetiracetam because it didn't help him, and he's completely seizure free right now. So it's not a conversion, or it's not a playing truant or whatever. It is a real thing. Okay. Okay, did you see this boy? He actually was sleeping, and every night, so he's got a frontal lobe epilepsy. First question is, you ask yourself, is this a seizure or is it not a seizure? And everybody will tell me that this is not a seizure because it happened during sleep only. And every night he has a couple of these episodes, but each of these episodes is exactly the same. It starts abruptly, it ends abruptly, and he goes, he turns around the bed, he screams. I don't know whether you could hear him screaming just now. There was a voice there hearing him screaming, okay? So it's not a nightmare, okay? This is a frontal lobe epilepsy. He had a lesion in the frontal lobe, all right? So frontal lobe epilepsy, nocturnal events sometimes are mistaken as parasomnias. So again, a video will be very helpful, okay? So in this boy, you can see that he has a dystonic right arm and a left arm that is moving, but his right arm is not moving at all. Can you see? This is a lateralizing sign. He has a lesion on the left side of the brain. All right. He has a lesion on the DNET on the left side of the brain. You can see that his arm is dystonic. This is a giveaway sign for a lesion in the brain, in the sense that he has a focal epilepsy with a dystonic arm. So the lesion is on the contralateral side of the dystonic arm. Okay, this is a young woman, a teenager who came in with this type of symptoms. You can see that what does she present with? You can see this is over, her seizure is over already. She's unaware. She's having oral automatisms and manual automatisms. Oral and manual automatisms. This is a classical aura of a left temporal lobe localization, okay? Classical aura, okay? So these are the refractory focal epilepsies. The two, this one that I showed you just now, they have MRI brain with lesions, cortical dysplasia, mesial temporal sclerosis here, this cortical dysplasia, DNET. These are all the lesions that need surgery and will be refractory to medication. So with this, I end my talk. And so do you have any questions to ask me? So thank you very much. Thank you very much.
There are some questions inside the chat box from our colleagues here.
All right.
Yeah.
Where is it? Wait, hold on. Let me see. Where's my chat box? Why can't I find my chat box now?
We can read it for you. So the first question is, do we need to monitor the LFT routinely in all patients who are started on valproate?
Okay, I would do a initial LFT as a baseline just to make sure that I can give them the valproate. I don't and then when it reaches I will repeat the LFT after a month, 2 weeks to a month. And then I would also, once it's maximized, I also just check one LFT. And the ones that I'm more particular is the ones that are actually, the ones that are, having a, what do you call this? Developmental delay, multiple therapy, developmental delay in multiple therapy. So I'm just kind of worried for them. And I'm worried that we may have, whether the etiology is a metabolic disorder. So I'm kind of worried about them, especially those with developmental delay. If I haven't excluded a metabolic disorder, I will actually not, I won't actually start them on valproate as the first choice, Yeah, I won't. Yeah.
Okay.
I think I can see your chat box now.
Yeah, about the question.
Yeah. Okay. So what was the question? Okay, let me read. I do monitor routinely, but I don't keep doing it once they are normal and we are dealing with the genetic generalized epilepsies and they're quite normal on let's say 20 milligram per kilo or 25 milligram per kilo and they have normal LFT. I don't do it like 6 monthly or anything lah. I just do it once. Yeah.
Okay.
Can we start an infant on valproate if lactate ammonia VBG is normal while waiting for IM screen? I usually don't, especially if it's a developmental delay. I don't because there's other choices for me to start. I don't use the valproate unless I'm sure that I've excluded the metabolic problem, So I'm a bit concerned when they're less than 2 years old, when they have developmental delay and they have myoclonic, they have tonic seizure, their EEG is bad. I don't know what I'm dealing with, so I rather not give them valproate.
Okay. Dr. Wong have a question here, I think. As you showed a video of the Indian young woman at the last part of the focal epilepsy where she was having the manual automatism.
Somebody said, if we cannot start on valproate, is it safe to put the patient on phenytoin? Most of patients do not respond well to Clona. Yeah, I agree. Okay, so you can depend on the seizure whether you need to load the patient on phenytoin or not. Then you can change to oral phenytoin. You can, but again, as I told you, you need to look at the EEG. You need to look at the MRI. And if the patient comes in with many clusters of seizure, many clusters of seizure, sometimes, the self-limited infantile and neonatal epilepsy can present with many clusters of seizure, but actually Their EEG can be normal, their development can be normal. Yes, it's okay to give phenytoin and then change to oral until we get the whole workout, until we get the MRI. And then these patients respond very well, and you don't even have to keep them for 2 years. You can wean them off within 6 months to 1 year, all right? But also depends on what epilepsy syndrome you're dealing with. Okay, so Indian young woman at the last part of focal epilepsy, oral plus manual, are they usually, okay, they are not aware of the movements, they are not aware, they are not responding during this time because as I showed you just now in the beginning of the talk, you remember the beginning of the talk, focal epilepsy, impact awareness. So when this young lady had when the parent call out to her, she's not responding, but some of them may have a bit of impact awareness. They may not be totally blank. They think that they hear you, but they cannot respond. But what happened is for this child, she couldn't respond. She couldn't. Only after the thing finished, she felt that something has happened because she lapsed consciousness. Yeah. So this is a very typical aura, the oral and manual automism is a very typical aura. Is this child actually, initially the MRI was reported as normal. Okay, and the EEG also is very, 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 very subtle, but I had a look at the MRI again, and there was something there on the left temporal lobe. So we probably maybe to do another MRI later with the what do you call with MRI with epilepsy protocol. So the interesting thing about this girl, she's brilliant in school, and she just got her epilepsy. She had a benign Rolandic SELEC. She got SELEC, self-limited epilepsy when she was young. The EEG was suggestive of SELEC, okay? Then she stopped having seizure at the 10 years old, right up to 15 years old now, okay? And then she had the COVID vaccine, and the parents blamed the COVID vaccine because they didn't go for Pfizer. They went for Sinovac on their own. But somehow, the whole epilepsy came out after that. And initially, we gave her, because we thought it's something benign. We didn't think it was what it was. We're not sure because she had been seizure-free and she's normal child. She's doing very well in school. So we gave her Keppra. It doesn't help. The thing became more and more frequent. We added on clobazam. It helped about Keppra. I think helped about maybe about 30 to 40%. Then we added on clobazam. It helped about 50%. Then I did the HLA-B1502 once I got the video because it's very typical of focal seizure. Meanwhile, because she was having many seizures, I started her on topiramate because Keppra doesn't help, the clobazam doesn't help. And on topiramate, she had 90% seizure reduction. But of course, the side effect profile, but she didn't have side effects. But when the HLA-B1502 came back, I switched her to CR carbamazepine, and she has had zero seizures since then. And she's doing quite well. So for me now, I just have to check and see what is the lesion we are dealing with. Okay, any other questions? I'm sure you all must be very, very tired listening to all these heavyweight talks. I hope that I've cleared some of your doubts already. And I hope that you all be better at handling on how to, start the medication. And you can always refer to the protocol. You can refer to the book.
Hi, Dr. Vicky. Lavinia here.
Hi, Lavi. How are you?
I'm okay. Dr. Vicky, I just clarify a doubt that I have. So if we diagnose a focal seizure, now we cannot start carbamazepine just like that, right? We have to wait for the HLA typing first, right?
I prefer, because I don't know, because our Han Chinese and our Malay population, they do harbor quite a bit of the HLA-B1502.
Okay.
And I feel that I do not want to take that risk if I have option, but I did tell the parents. And when you tell the parents about this is the best drug for this patient, I feel, based on the MRI, based on the EEG, but there is a small percentage of you getting this. it may or may not be dose dependent, you see. Sometimes it can be idiosyncratic. Even a tiny dose, it can just come up. And even if you stop the medication, it can just go on. Like one of my patients previously in the past, but luckily it wasn't full-blown Stevens-Johnson. But I have started a few patients in the ward because I had no choice and the seizures were terrible. But I told the parents that, look here, you might get a potential to have this problem. I will start very slow and we'll off it the moment we see a rash. But it can progress if you are idiosyncratic. That is a very rare chance that it can progress despite you quickly off it, you know.
Okay.
So,
so
because then if parents said okay, then if they say okay, I accept that very rare chance. You just start it, then I will start lah at a very low dose and I'll observe the patient in the ward. But very few occasions lah.
Will it be safer to then start Keppra first as a?
Yeah.
That'll be an easier option.
It'll be an easier option, or Valproate. Valproate, if it's a prepubertal child, Valproate. But Valproate doesn't work well for focal seizure, but people who are allergic to carbamazepine, sometimes there are few patients who respond, but in my experience, most don't. But having said that, one or two do, but you are just buying some time, or you can use clobazam, or you can try lamotrigine. But the problem is if you have a florid seizure, you want to give lamotrigine, it's going to be hard because it's a 2-weekly increment. It will take 3 months to achieve its level. It will take 3 months to achieve the minimum dose that you need for the child.
And in your experience, how long does the HLA typing take to come back?
Sometimes we put pressure on them. So we ask for early appointment. We can ask for early appointment. So they give us an appointment within a month and then the result comes back within a month. So about 2 weeks, 2 months.
2 months.
Yeah, about 2 months. But having said that, one of my patients even did in Gribbles. They paid, I think I think it was about 600 ringgit. And they got the results within about 3 weeks before COVID that time, because the parents wanted to pay for that result.
Okay.
But I don't tell them lah. I don't tell them about payment because it's messy.
Yeah. Okay, thank you, Dr. Vicky.
Okay, welcome. I know Keppra is not the best solution, but because I feel that it doesn't really work that well, but it's actually used a lot because it's relatively kind of clean, safer profile lah, of the side effect profile. But then patients, some of my patients can get very, very hyperactive. Some can even go into psychosis. There's a tuberous sclerosis patient that went psychotic in the ward, and the mother cried for days because she couldn't believe her child had become like that, even with 1 dose of Keppra. So it can do things like that. So it's not the answer to everything. Yeah.
Dr. Vicky, sorry, I want to ask the last question. You mentioned that the Valproate should not be given to childbearing age. I mean, how if those teenager girls, of course they are not married yet, but sometimes they have, out of wedlock pregnancy, though unexpected one. So in this kind of case, do we go to lamotrigine or we still can give Valproate?
Yes, I don't give Valproate. I try not to give Valproate because it's a product insert already, and we just worried lah, because there is everybody is announcing it's big, it's in a protocol book, and then everybody overseas is knowing that we try not to give Valproate for women of childbearing age. But having said that, I have switched my patients to either lamotrigine or Keppra. But if it's a focal seizure, I'll go for carbamazepine.
So as long as they hit pubertal, then we will avoid Valproate by any means.
I try, unless, but there are some cases that I keep. But in these cases, I know that they are going to go into remission. That means I know that they don't need the Valproate long term. I know that I'm going to off the Valproate. And I do counsel the patient, because there's I tell you one real case. This is a 12-year-old girl from KL. My colleagues in my pediatric neurology colleagues in KL, the child had actually she said that the child was labeled as absence epilepsy and was started on lamotrigine because of pubertal. They didn't want to give Valproate. Okay, So the patient came to me because the parents moved here, and then I continued the lamotrigine because the patient was having absence, but mostly the patient was having GTC. Mostly GTC. So it's not a childhood absence. It's 12 years old already. It doesn't fall into a childhood absence. It could be JAE, juvenile absence. So patient was having a GTC, like 2 weekly, 1 episode. And the worst was when I saw the EEG, it's also generalized discharges, and the lamotrigine was already maxed out, maximum ready, and she was still having this. And once in school, she fell down and she, hit her lip and all these things. So I told the mother about valproate, and I told the mother about Keppra. And actually, I told the mother about all this, and the mother wanted valproate, chose valproate over Keppra. And I gave her valproate, and she had 0 seizures, no more seizure at all. But I was hoping that the valproate can be offed in another 2 years. I was hoping that the valproate can be off. So I told the mother, I'm giving you this now, but I'm not going to maintain her on valproate long. So, but with the valproate, is actually 0 seizures, 0. But I probably will switch her on later, maybe after 2 years, maybe I'll switch her on to Keppra. I haven't seen her recently, so I'm not sure what's happening to her. But the mother, like, I told her about Keppra, I told her about valproate. The mother said, I want valproate, and she really had no seizure lah. And it was quite a low dose of valproate also. But I think if she goes on to 15, 16 years old, I'm going to off that valproate, and I'm going to probably switch her to levetiracetam because lamotrigine doesn't really help her.
Thank you, Dato'.
Okay, I think you all better go and have your lunch.
Thank
Sorry
you.
for dragging it a bit.
Okay, we are very thankful because we learned this is a very important topics for us, and
Thank you.
we are very grateful for your
Thanks.
teaching.
Thanks for the invitation. And this is my favorite topics as well.
Thank you so much.
Okay, thank you. Thank you. Bye-bye.
Have a great
I might join you all later at 2 o'clock.
Okay, thank you.
1:40. When's the next session? 1:40.
Next session will be 1:45. It's an AEEG by Dr. Eric.
Okay.
Okay, thank
See
you.
you all. Thanks. Have a good lunch. Bye-bye.
Thank you. Bye-bye. Open queue 是什么？ Oh, okay. Thank you. So we are having a break now, and please be here by 1:45. The next topic will be by Dr. Eric at 1:45 p.m.